So here is a picture of the neuromuscular junction. You have your motor nerve fiber right here. Then you have your muscle fiber right here. This is your actin and myosin complex. You can see mitochondria within the muscle fiber and the axon. You have also got transmitter vesicles right here. These vesicles contain acetylcholine. Typically, what you'll have too, it's not pictured in this, but you'll have voltage-gated calcium channels on the outside of this axon. As far as the muscle fiber goes, you have the acetylcholine receptors, which are right here. And you'll have acetylcholinesterase, which will, in the end, break down the acetylcholine, and that's typically housed in the end of these, in this part right here. So we'll kind of run down the whole transmission process. This is without any drugs. This is just to give you a basic idea of how a normal physiology works, and then we'll discuss later the mechanism of the depolarizing and non-depolarizing agents, so we have an idea of what we're looking at whenever we go into detail. So normally a nerve's action potential will be sent down and it depolarizes the terminal. Right here's the terminal, and as it depolarizes it, this causes a calcium influx through those calcium channels that I discussed that aren't pictured here, which will then cause a release of acetylcholine from the storage vesicles here. Acetylcholine then will diffuse across the synaptic cleft. And the synaptic cleft, it's very, very small. It's about 20 nanometers between the nerve terminal and the muscle fiber. And then once the acetylcholine diffuses across the synaptic cleft, it'll bind. It's going to bind with the nicotinic cholinergic receptors that I showed you earlier. Just a tidbit of information. Each neuromuscular junction has about 5 million receptors, but a muscle contraction will only require 500,000 of those receptors to be activated. So, so when acetylcholine binds to the receptor, it'll bind to 2 alpha subunits on the receptor itself. The ion channel in these receptors opens, and cations are then allowed to flow through the channel. So you'll have sodium and calcium that goes in and potassium that goes out. Once a threshold voltage is developed through these cation influxes, a voltage-gated sodium channels open in the perijunctional areas and cause an action potential that propagates along the muscle membrane. So these perijunctional sodium channels, they become activated, and then just as quickly as they're activated, they become inactivated. This is a very important concept whenever we discuss the mechanism of action for your depolarizing agent. So sodium channels open and release calcium from the sarcoplasmic reticulum. This intracellular calcium release allows actin and myosin to interact then, and this is essentially what will cause the contraction within the muscle. After this has happened, the acetylcholinesterase, which is embedded in the motor end plates that I talked about, it will then hydrolyze the acetylcholine. Once the acetylcholine is unbound, it unbinds into acetate and choline, and the receptor ion channels close, and then the end plate then repolarizes. So that's kind of the entire cycle for this transmission. right. Now I'm going to go into the mechanism of action for both the classes of drugs for neuromuscular blocking agents, which would be depolarizing and non-depolarizing. So the only depolarizing agent would be succinylcholine. They act essentially as an acetylcholine receptor agonist. And so succinylcholine, it closely resembles acetylcholine in that it's two acetylcholine molecules that are bound together, and this will readily bind to the acetylcholine receptors, which will cause a muscle action potential. Succinylcholine isn't metabolized by acetylcholinesterase, therefore you'll have a relatively prolonged depolarization of the motor end plate there. So when you get this relatively prolonged depolarization at the end plate, the perijunctional sodium channels become inactivated. Like I discussed earlier, this is a very important mechanism for succinylcholine because these sodium channels can't reopen until the end plate repolarizes. So long as that succinylcholine is bound to that receptor, there's a constant depolarization, and the perijunctional sodium channels can't then become active. So at this point, you'll see a phase 1 block in your patients, which is just a constant but diminished response whenever you use your peripheral nerve stimulator. With subsequent doses of succinylcholine, you can see a phase 2 block, which essentially mimics your non-depolarizing drugs, and you'll see a fade in your patients whenever you use your peripheral nerve stimulator. Okay, so now we'll go into the non-depolarizing agents. These agents act as competitive antagonists. The mechanism of action that you'll see with non-depolarizing muscle relaxants, you'll see them bind to acetylcholine receptors, but they can't induce an ion channel opening. Because acetylcholine is prevented from binding to the receptor, then the end plate potential cannot develop. And so these drugs are unique in that they only have to bind to one alpha subunit to work. And because they prevent this potential from happening, that's whenever you will see your muscle paralysis occur. All right. Now we're going to discuss succinylcholine in depth. We'll talk about a few things. First is the metabolism of succinylcholine. It's metabolized by acetylcholinesterase, and this process is so efficient that only a small amount of the injected drug that you give will actually reach the neuromuscular junction. However, you can get increased duration with these drugs whenever you give higher doses, or you give infusions, or there's an abnormal metabolism with the patient. Some drugs that will decrease the acetylcholinesterase activity include organophosphates, cholinesterase inhibitors, metoclopramide or Reglan, esmolol or pancuronium. Some pathologies that can decrease acetylcholinesterase levels would include liver disease, renal failure, and pregnant patients. Although you'll get a decrease in your acetylcholinesterase in your parturients, it won't affect the duration of your blockade with succinylcholine. So some advantages of succinylcholine would include a quick onset and quick offset. It's ideal for your rapid sequence inductions, patients with full stomachs, people coming in for emergent surgeries, and there's no need to reverse because it's so short acting. Some disadvantages to using succinylcholine is you can see hyperkalemia. You can increase your serum potassium by 0.5 milliequivalents per liter. So you basically need to watch out for patients, burn patients, trauma patients, spinal cord injury patients, people who are having a stroke, closed head injury, intra-abdominal infection as well. Myalgias are another disadvantage with succinylcholine. I've read that perioperative use of NSAIDs can reduce the severity of myalgias. You can also give a defasciculating dose with rocuronium. Another disadvantage is increased intracranial pressure. You can increase cerebral blood flow in some patients. And it's important to make sure you secure a good airway and hyperventilate in these patients. It's not contraindicated for patients with intracranial pressure, but it's a relative contraindication. You can also alleviate some of the pressure increase with a neuromuscular blocking drug such as rocuronium and lidocaine. I believe Morgan and McHale says 1.5 to 2 milligrams per kilogram prior to induction will help alleviate this. You can also get some masseter muscle rigidity. Repeat doses with succinylcholine can induce arrhythmias or bradycardia. Patients with atypical pseudocholinesterase can be an issue. These patients, you can prolong the blockade from succinylcholine for up to 4 to 8 hours. Anybody who's told you that they've had a family history with an atypical pseudocholinesterase, they need to have their dibucane number checked. Patients with that are homozygous atypical will have a dibucane number typically around 20. A normal patient will have a dibucane number around 80. And this dibucane number, it essentially measures the function of the pseudocholinesterase, not the amount of pseudocholinesterase that's at the neuromuscular junction. Some other issues with succinylcholine, you can get a histamine release that's reported. It's reported that there's a slight histamine release, but nonetheless there is one. And it can induce malignant hypothermia. It is a potent trigger in patients who are susceptible to malignant hyperthermia. So, some dosages in adults, on induction you'll do 1 to 1.5 milligrams per kilogram IV, and this is based on total body weight. You can give a maintenance dose at 0.15 milligrams per kilogram, and although I haven't seen it yet, but you can do an infusion at anywhere from 2 to 15 mics per kilo a minute. Some characteristics of succinylcholine: you'll have a very quick onset, like we said, anywhere from 30 to 60 seconds. You can have a peak time in your muscle blockade of 60 seconds, and it can last as long as 4 to 6 minutes, with a half-life of 1 to 2 minutes. The rationale for using succinylcholine, like we kind of went over earlier, you can use it in your rapid sequence induction or cases with short duration when no paralysis is needed. Now we'll go into rocuronium. Like we discussed earlier, it's a non-depolarizer, so it's a monoquaternary aminosteroid, intermediate acting, Metabolism, there's no deacetylation, and it's excreted primarily by bile and a little bit by your kidneys. Advantages of rocuronium: it can be used as an alternative for your rapid sequence because it does have a rapid onset. No cardiovascular effects or histamine with this drug. Disadvantages: you can get a longer, I should say, blockade with larger doses of rocuronium. Some side effects, contraindications in patients with renal or liver disease. Vagolytic effect may cause tachycardia and arrhythmias. The dosage is 0.6 to 1.2 milligrams per kilo. An ED95 of patients is 0.3 milligrams per kilogram. And you can use it as a defisculating dose, like we said earlier, at 0.06 to 0.1 milligrams per kilogram. You'll see an onset of about 1 to 2 minutes with a peak of muscle blockade in 2 minutes, and it can last anywhere from 30 to 60 minutes. The rationale for, as it says, you can get a rapid onset. You can use it as an alternative to succinylcholine, and no cardiovascular effects, no histamine release, and it's not a trigger for malignant hyperthermia, and it must be reversed. Vecuronium, it's an aminosteroid, intermediate acting as well. It's metabolized hepatically and excreted renally. Some disadvantages of vecuronium: the block can be potentiated by local anesthetics, inhalational agents, loop diuretics, magnesium, lithium, hypothermia, hypokalemia, respiratory acidosis, and prior succinylcholine use. Side effects would include a prolonged half-life with in patients with renal or hepatic failure, faster onset with prolonged effects in infants, prolonged effect in the elderly due to the decreased volume of distribution. Your dosage on induction for vecuronium will be 0.08 to 0.1 milligrams per kilogram, and you'll see a maintenance dose of 0.1 milligrams per kilogram, and infusion at 1 to 2 mics a kilo a minute. It's got an onset of 2 to 4 minutes. It'll peak in 5, and you'll see a duration of 30 to 60 minutes. Some rationales for using vecuronium: no cardiovascular effects, no vagolytic effects, no histamine release, can be reversed, and it's, along with rocuronium, is not a trigger for malignant hyperthermia. Atracurium, it's a benzolysoquinolinium that is intermediate acting. It's metabolized by Hoffman elimination, which is dependent on the pH and temperature. Plasmasterases and renal excretion. Advantages for using atracurium: there's no cardiac muscarinic effects, no nicotinic effects at the autonomic ganglia as well. Disadvantages: primary metabolite is lidanosine, and this acts as a cerebral stimulant. One disadvantage is it needs to be reversed. Side effects include histamine release. Repeated or high doses can cause hypotension and tachycardia. So your induction dose with atracurium is going to be 0.3 to 0.5 milligrams per kilo. Your maintenance, you'll see at 0.1 to 0.2 milligrams per kilo, and infusion rate at 5 to 12 mics a kilo a minute. Some characteristics: you'll see onset of 2 to 4 minutes, peak of 5 minutes, and duration of 30 to 60 minutes. The main reason when you'll use for using atracurium is it's not dependent on renal or hepatic elimination, and there's no cardiac effect. So in patients that come in with renal disease, it's good for them. The next one is cisatracurium. It's also a benzolysoquinolinium that's intermediate acting. It's metabolized by the Hoffman elimination as well. There's no cardiac impact even at higher doses, and no histamine release. Still needs reversed. And some side effects that you'll see: you do have lidanosine metabolite as well. Some dosage. The dosages, it's 0.15 to 0.25 milligrams per kilo, maintenance at 0.02 milligrams per kilo, and an infusion at 1 to 2 mics a kilo a minute. You'll see an onset of 3 to 5 minutes, peak in 5 minutes, and a duration of 30 to 60 minutes. It, along with atracurium, isn't dependent on liver and renal elimination and does not have cardiovascular effects. Pancuronium, it's a bisquaternary aminosteroid that's long-acting. It's metabolized by the liver, excreted renally, and by the biliary system. Advantages for using pancuronium: you can get a prolonged block for longer cases, essentially. Disadvantages: prolonged blockade in renal failure patients, and you can see a 10 to 15% increase in your heart rate, MAP, and your cardiac output. Your dosages on induction: 0.08 to 0.12 milligrams per kilogram, and with a maintenance of 0.01 to 0.04 milligrams per kilogram. Some characteristics: you're going to see an onset of 2 to 3 minutes, peak of 5 to minutes, and a duration of 60 to 90 minutes. So I just came up with a few questions to kind of sum up the PowerPoint. And I'll just let you read them. All right. So drugs that cause histamine release, you have succinylcholine, which I mentioned earlier, has a minimal histamine release, and atracurium as well as mivacurium. We don't use mivacurium here in the United States, so I didn't include that in this PowerPoint. Drugs for patients with end-stage renal disease, the atracurium and cisatracurium, because they're both independent of renal metabolism, therefore it's a good drug in these patients. Ledanosine, like we said earlier, it's a metabolite of atracurium. It's associated with central nervous system excitation, and it can cause seizures. Number 4, that was the heart rate. Which drugs affect the heart rate? Succinylcholine can decrease heart rate by stimulating the cardiac postganglionic muscarinic receptors, and pancuronium can cause tachycardia by blocking cardiac muscarinic receptors. Number 5, adverse effects with succinylcholine. You can get cardiac dysrhythmias with subsequent doses. You can see fasciculations, hyperkalemia, myalgias, myoglobinuria, increased cranial pressure, increased ocular pressure, master jaw rigidity, and it can trigger malignant hyperthermia. Number 6, they just discuss the mechanism of action for these drugs. So depolarizing agents act as receptor agonists, whereas non-depolarizing agents act as competitive antagonists. The Dibukane number, like we discussed with your homozygous atypical pseudocholinesterase patients, it essentially patients with atypical homozygous, you're going to have a number around 20, and normal patients without pseudocholinesterase deficiencies, you'll see a Dibukane number around 80.